In this video, you are supposed to learn the inner anatomy of the pelvis, the anatomy of the bladder, the normal maturation, what happens in neurogenic bladder, and how to manage it. Pelvis is a basin-shaped cavity. The basin has a false pelvis, which is less oblique, and a true pelvis, which is more oblique, and it is separated by the pelvic rim. Now, in this diagram, here is the pelvic rim. So, this pelvic rim separates the false pelvis and the true pelvis. Now, from anterior superior iliac spine to the pubic tubercle is a ligament which is called as the inguinal ligament. Then, this whole pelvis is suspended by abdominal muscles, the transversus abdominis, the internal oblique and the external oblique, and this is how you see the innermost muscle, which is the transversus abdominis. Behind you see the quadratus lumborum. Then, under the inguinal ligament emerge the iliacus and the psoas. The iliacus and the psoas muscle. Under the medial to the psoas muscle is the femoral nerve, the femoral artery, and the femoral vein. So these are the contents that form the false pelvis. So I will repeat it on this diagram. Suspended by abdominal muscles, and then you have the iliacus, the psoas, the nerve, the artery, and the vein, and then I continue with the false pelvis, the true pelvis. And the true pelvis, you have a muscle here which is called as the obturator internus. Outside that, you see the head of the femur in the acetabulum, the neck and the trochanter. So thus this basin-shaped cavity is supported by two lower limbs, and it basically supports the spine through a sacroiliac through the sacrum. It supports the spine, and this basically joins the sacrum by the sacroiliac articulation. So this is the pelvis. And what I want to tell you here is that there is a fascia transversalis which covers the obturator internus muscle, the obturator internus of this side too, and there is a tendon of the levator ani, and this levator ani muscle is peculiar because the levator ani of the two sides are horizontal. So above the levator ani is the pelvis, and below is the perineum. The slit between the levator ani which you see here, passes the urethra in front, that means the urine, the vagina, that means the baby, and the anal canal, that means the stool. So basic function of the pelvis is that it is suspended by the abdominal muscles. It has a true pelvis and the false pelvis part divided by the medial border of the pelvis or the pelvic rim. The false pelvis is less oblique, the true pelvis is more vertical. In the true pelvis, lining its medial surface is the obturator internus muscle covered by the fascia transversalis and the tendon of the levator ani. The levator ani divides the true pelvis into above the levator ani, which is the pelvis, and below the levator ani, that is the perineum. Now, the perineum that you see, if this is the pubic symphysis, this is the medial border, this is the auricular process, this is the greater sciatic notch, the ischial spine, the lesser sciatic notch, the ischial tuberosity and the ischiopubic ramus, and this is the obturator foramen, and here you have the sacrum. Then this ligament is sacrotuberous ligament, and this is the sacrospinous ligament. The obturator internus muscle arises from the inner surface of the true pelvis and goes out of the lesser sciatic notch. So this is the obturator internus muscle. Here is the tendon of the levator ani. Here is the tendon of the levator ani from the ischial spine to the pubis, and the levator ani muscle. I will draw it in a different zone. Is a horizontal muscle that extends from the levator ani tendon and actually goes to the coccyx, but the levator ani of this side and the levator ani of this side actually encloses a slit or a space. It encloses a slit or a space, levator ani of this side encloses a slit or a space which passes the urethra and the bladder in front, uterus and vagina behind that, and anal canal and rectum in the posterior part. So this is the rectum and rectum, this is the uterus and vagina, and this is the bladder. So the slit will pass the anal canal, the vagina, and the urethra, which is coming from the bladder, and we will deal with this area in the rest of the talk. Bladder is a pyramidal structure. It has got a superior surface, two anterior surfaces, as here is the pubic symphysis, and these are the obturator foramen. So it is placed like this in the pelvis. Superior surface, posterior and anterior left and right surface. On this angle is the urethus. On this angle the ureters. And on the lower angle the prostatic urethra, around which is the prostate. The prostatic urethra ends in a membranous urethra which lies in the deep perineal pouch and is surrounded by the external sphincter, supplied by the pudendal nerve. Then the membranous urethra lies in the corpora spongiosa and becomes what is called as the perineal urethra. That perineal urethra is attached by the dorsal ligament to the pubic symphysis. So here is the pubic symphysis by the dorsal ligament. This is attached by the dorsal ligament to the pubic symphysis, and then it curves down into the penile urethra. So the urethra has got a prostatic portion, a membranous portion, a perineal portion, and a penile portion. The vein of the penis pierces the dorsal ligament of the penis and comes to lie around the bladder veins, and therefore if the bladder is distended, these veins are pressed between the fascia transversalis and the bladder, and this vein, dorsal vein of penis, gets engorged, and that leads to erection of the penis, which can be painful, and this is called as priapism. So in the urachus, sometimes there is development of the urachal cyst, which you can palpate in the midline below the umbilicus, and sometimes there can be a fistula where the urine passes from the bladder through the umbilicus. So this is a urachal fistula. This bladder is developed from the vitalo-intestinal duct, and this is by this urachal cyst and fistula formation. Now, coming from the anti-abdominal wall, winding round the ureters from the two sides are the vas deferens. These vas deferens are connected to the seminal vesicles where they collect the sperm. They become ejaculatory ducts. And open into the prostatic urethra, into a bulging portion of the prostatic urethra called the viru montana. Now we will deal with, see the urethra, this bladder from inside. So we will draw the prostatic urethra. We will draw the deep perineal pouch, the superficial perineal pouch, and this urethra that is lying in the deep perineal pouch is called as the membranous urethra. Now this urethra is called as the prostatic urethra. It is beginning in the bladder. As it pierces the deep perineal pouch, this urethra becomes the perineal urethra, and that perineal urethra becomes the penile urethra, connected to the inferior part of the pubic symphysis by the dorsal ligament of penis. Okay. Now, the superior most structure in this prostatic urethra is the bulge of the prostate gland, and that is the bulge of the median lobe of the prostate gland. Then there is a posterior urethral crest, and there is a verumontanum on which there is a utriculus masculinus, and there are openings of the prostate gland here. The membranous urethra is surrounded by the external sphincter, which is supplied by the pudendal nerve. So this is the structure of the prostatic urethra, and it is in the utriculus masculinus that the vas deferens discharges the sperms, which are non-motile, but the prostatic fluid coming out of the prostate gland makes these sperms motile and they start moving. So this prostatic fluid basic function is that it activates the mitochondrial system of the sperms, so they start moving and become motile from immotile. So after this, in the bladder itself, we are making this as a mucosa. Mucosa has got a smooth part which is smooth and a rugose part which is around this. The smooth part is called as the trigone. It ends in the median lobe, bulge of the median lobe of the prostate. On the two sides you have the ureteric orifices. Normally when the bladder contracts, these ureteric orifices are collapsed and they prevent a ureteric reflux. But in tuberculosis, they fail to close. Therefore, the ureteric reflux is present, and such ureters are called as golf hole ureters.
Hello, sir.
Hello, how are you? Well, outside the mucosa is the muscle. The peculiarity of the bladder muscle is that it's more longitudinal superficially and transverse deep. The transverse portion of the muscle thickens in its lower part and becomes the internal sphincter. The upper portion of the muscle has got a mechanism peculiar to it and the uterus, which is called as the ratchet mechanism, which makes the muscle contract, but while it relaxes, its original length is maintained. Like any other muscle, it doesn't relax to gain the original length. So this retention of the contracture is called as retraction. So it contracts, relaxes, but retracts, like the uterine muscle. The second thing is that there is a fascia transversalis outside it, and the veins are placed between the fascia transversalis and the muscle, and the blood vessels pierce and supply the mucosa, the arteries. So if the bladder is distended, the veins stop, the veins stop draining, the arteries keep on pumping blood, the mucosa becomes congested and becomes hemorrhagic, and there is hematuria. Therefore, if you leave the bladder distended, there will be hematuria. Therefore, in all cases of neurogenic bladder where there is retention, it is important to put in a continuous catheter. Well, outside the mucosa is the muscle. The peculiarity of the bladder muscle is that it's more longitudinal superficially and transverse deep. The transverse portion of the muscle thickens in its lower part and becomes the internal sphincter. The upper portion of the muscle has got a mechanism peculiar to it and the uterus, which is called as the ratchet mechanism, which makes the muscle contract, but while it relaxes, its original length is maintained. Like any other muscle, it doesn't relax to gain the original length. So this retention of the contracture is called as retraction. So it contracts, relaxes, but retracts, like the uterine muscle. The second thing is that there is a fascia transversalis outside it, and the veins are placed between the fascia transversalis and the muscle, and the blood vessels pierce and supply the mucosa, the arteries. So if the bladder is distended, the veins stop, the veins stop draining, the arteries keep on pumping blood, the mucosa becomes congested and becomes hemorrhagic, and there is hematuria. Therefore, if you leave the bladder distended, there will be hematuria. Therefore, in all cases of neurogenic bladder where there is retention, it is important to put in a continuous catheter. So after the anatomy of the bladder, let us understand the physiology. The ureters fill the bladder with 400 cc's of urine. At that time, the internal sphincter, there is a local stretch reflex that increases the activity in the bladder wall, local reflex, and that relaxes the internal sphincter. So this increases local activity and internal sphincter relaxes. And therefore, some urine trickles into the prostatic urethra. This is the prostate. Here is the deep perineal pouch, and above, then you have the superficial perineal pouch, and here you have the membranous urethra leading to the perineal urethra, which goes on for the penile urethra. So on the prostatic, some urine trickles into the prostatic urethra where there are chemoreceptors, and these chemoreceptors stimulate the spinal cord. They stimulate the spinal cord, and from the spinal cord, impulses start coming to the bladder where the ureteric orifices are. Now, in the local reflex, the contraction is not coordinated. It is at local spaces like this, like atrial fibrillation. So this local reflex is uncoordinated, but this spinal reflex causes coordinated contractions from both the ureteric orifices. And also, this spinal cord conveys to the cortex that you need to go to the bathroom. The cortex, through the pudendal nerve, stimulates the external sphincter, and this external sphincter contracts and prevents the urine from being done at a place where it is inappropriate. Also, the cortex guides you voluntarily to the toilet. There, the pudendal nerve relaxes and urine starts flowing out of the perineal urethra, membranous urethra, perineal urethra, and goes into the penile urethra. Now, as soon as that happens, the volume of 400 cc in the main bladder decreases, and thus the stretch reflex, which is originating here, local reflex, is obliterated. But the spinal reflex keeps on, because till the urine is passing over the prostatic urethra, the chemoreceptors, the spinal reflex continues till the last drop of urine is out. That means the post void after maturation, residual volume is less than 50 cc. So this is how there is a complete evacuation of the bladder at the end of normal maturation. Now we move on to spinal cord injury. As soon as the spinal cord injury occurs, the electrical activity of the spinal cord is dependent on the reticular activating system in the midbrain. So that is in the midbrain, the pons, the spinal cord, and this reticular activating system, the descending fibers are maintaining the electrical activity in the spinal cord. So as soon as there is injury of these fibers, the reticular activating activity is gone, and thus the electrical activity of the spinal cord is gone. So spinal reflex becomes absent, and local reflex is also absent. And in this stage, it is called as neurogenic retention. Then the local reflex comes back, and then where there is over distension, there is fibrillar activity of the bladder wall. Internal sphincter relaxes and some urine passes in a dribble. Some evacuation. Therefore, high post-void residual. So this is when the local reflexes become active, and this is called as overflow incontinence. And this increase in post-void residual is at least more than 100 cc. And such a bladder is called as autonomous bladder. Then the spinal reflex returns. Now the urine is evacuated in a stream. So there is a stream. And the post-void residual, that means evacuation is almost complete and the post-void residual is less than 100 cc's. And this bladder is called as automatic bladder because it's only controlled by filling. Neither it is giving the sensation to the brain, nor it can be the micturition can be controlled by the brain. So this is the automatic bladder. But then sensations start going to the brain, so that is called a sensate bladder. And finally, some sort of motor control partially returns. Leading to two differences from a normal bladder. The first difference is hesitancy. That means it takes time for the micturition to start. And the second is precipitancy. That means you can't hold the urine till you reach the toilet. So hesitancy and precipitancy are signs of partial motor control of the bladder. Therefore, the neurogenic bladder is neurogenic retention, autonomous bladder, automatic bladder, sensate bladder, and partial control, motor control, which is hesitancy and precipitancy. Now, how do you manage it? In the retention, till you reach a proper place, continuous catheterization is important, because otherwise, because of over distension, the veins these are the veins between the fascia transversalis and the bladder muscle. They will get clogged. But the arteries which are crossing the muscle and supplying the mucosa will continue pumping blood. Therefore, mucosa will get congested and will start bleeding. Therefore, there is hematuria if you do not put a continuous catheterization while the patient is being transported to a spinal cord injury center. Then, autonomous bladder is treated by intermittent catheterization. It is usually a K90 catheter, which is a simple catheter, and it is put in. Supposing you have to evacuate 2400 cc's in 24 hours. Then you want the bladder to distend 400 cc's between two evacuations. Then you must evacuate 2400 upon 400. That means 6 times. So 3 times in morning, in day, and 3 times at night. You have to evacuate by this intermittent catheterization. And what you actually do is that if this is the pubic symphysis and here is the bladder, then you put your fist on this point and press, and you evacuate. This is known as Creed's method of evacuation. After manual evacuation, you put in a catheter and measure the post-void residual. When the post-void residual is less than 100 cc's, then you stop intermittent catheterization and maintain evacuation by Creed's method. So this is the method of management of neurogenic bladder. Now what can be the complications of a neurogenic bladder? As I told you, first is hematuria. The second is cystitis. Now this cystitis can go into the ureter, ureteritis, pyelonephritis. It can go into the urethra, urethritis, and this urethritis can lead to urethral fistula or periurethral abscess. Then after the urethritis, there can be prostatitis, seminal vesicles or vesiculitis, vas deferens or funiculitis, and then epididymis and testes, so epididymoorchitis. The pyelonephritis can lead to chronic end-stage renal disease, and persistent infection can also lead to amyloidosis. So these are the various complications of neurogenic bladder. But if you leave the catheter all the time in continuous catheter, then the bladder will become small because it has remained contracted for a very long time. This bladder is called as thimble bladder, and you need an ileum to increase its volume. So this operation is called as ileocystoplasty.